Okay, so in more realistic fashion, the reason we would be using the endovaginal probe would be to identify an intrauterine pregnancy that we could not see with the transabdominal probe. That, or we'd be scanning the adnexa for any findings suggestive of an ectopic pregnancy. But remember, our goal is to rule in intrauterine pregnancy, to rule out ectopic. So inserting the probe into the vagina, again with the probe indicator at 12 o'clock position, we see the uterus come into view. And again, the right side of our screen is the cervical region over here. And this is the fundus. And as I fan through the fundus of the uterus, then I see a gestational sac. And more realistically, I see a yolk sac. And so this may have been an early pregnancy that I was incapable of visualizing with the transabdominal probe because it was so early. In this demonstration, it's difficult to see the heart flicker, but most of the times you can see a fetal pole, you'll be able to see the flicker. In fact, if the fetal pole is 5 millimeters or greater in length, we should always see a heartbeat. And if we don't, then we should have concerns about intrauterine fetal demise. But there you see the fundus of the uterus, you see the thickened endometrium, you see at least 5 millimeters of myometrium surrounding the gestational sac, so that we know that this is not an interstitial pregnancy. And this is the long axis of the uterus. I'll now turn the indicator to the short axis where we're getting a coronal view. And again, we can see there's 5 millimeters of myometrium around the gestational sac. We can see the fetal pole, and we can see the yolk sac. So in this case where this patient came in with pain or bleeding or both, this finding of an intrauterine pregnancy can be confirmed by the fact that we have a gestational sac with a yolk sac, or a gestational sac with a fetal pole and a heartbeat, giving us reassurance that there's no ectopic pregnancy. Now, we can never fully rule out ectopic pregnancy with ultrasound. We're basically playing the heterotopic odds. Most recent literature reports that that's between 1 in 3,000 and 1 in 14,000 in terms of having a heterotopic pregnancy. So the odds are greatly in our favor that we're not going to miss that. Nonetheless, we can then look in the adnexa. We see over here the right pelvic sidewall with the vessels on the far left of the screen. And as we fan through, we pick up the ovary with a corpus luteum cyst. And as we move to the left adnexa, again we see another ovary with a few follicles, and that ovary is medial again to the pelvic sidewall and the iliac vessels there. Now, if the lady is on fertility medications, we just assume that she harbors a heterotopic pregnancy. And this is a scenario that I always recommend to our residents. We get OB consultation, and secondly, we get formal ultrasound to do the scanning as well, because we just presume if she's having pain or bleeding in a scenario that she's on fertility meds or had in vitro fertilization, that she could harbor an ectopic that we could miss. And skill level is very important. It takes quite a bit of practice to be confident with what you're seeing and what you're doing with an endovaginal probe. That said, it's not profoundly difficult. It's something that all emergency practitioners with practice should be capable of doing. And that shows us on the screen image what we typically would see with endovaginal ultrasound if we could not identify an IUP with the transabdominal probe.